So some of you said that you didn't get a lot from the pharmacology lecture that we went through back in March. So I thought I'd do a recording and go through a PowerPoint that I had built for us at work. This will cover the things that are in your book, plus a couple other little things that real life we do. All right, we don't do a ton of medicines as a basic EMT. Oxygen is considered a medicine, and that's probably the one we use the most. Narcan's right up there too. We'll talk about each of these medicines that we might deal with. There's aspirin, oral glucose, oxygen, of course, the person's inhaler, nitroglycerin, epinephrine, Narcan, and albuterol. So aspirin, what do we use aspirin for? Pretty much any chest pain call, we can give aspirin. We should be carrying it on our ambulances. For chest pain that might be cardiac related, if the person's having angina, which is chest pain, but it's not a heart attack. We're not going to diagnose the difference. If they're having chest pain, we can give aspirin for it. We can give up to 324 milligrams of aspirin. That'll be 4 baby aspirins. The person must have the ability to swallow, and we may give an additional dose we may give more if a dose has been given prior to arrival. What we mean by that is the protocol says that 324 milligrams can be administered by a basic EMT. The patient shouldn't be taking a large amount of aspirin, but they may have already taken some. So when we get there, we'll say to them, are you allergic to aspirin? Have you ever taken aspirin before? If the patient says, yes, I just took 1 baby aspirin, we can give up to 324 milligrams. So instead of giving 4, we would give 3. And I hope that doesn't complicate things. The most important thing for us to remember is we can give up to 324 milligrams of aspirin for a chest pain call. All right, we'll give oral glucose. We talked about this in the diabetic section last week. Okay, if the person's having altered mental status and they're hypoglycemic, then we can give oral glucose. But what is low? If you go back and listen to that section on diabetes, they say around 60 or lower is low. Every person's a little bit different. So if you get to a patient and their blood sugar is 66 and they're acting altered, you can give them oral glucose. Giving them oral glucose is not going to kill them if their blood sugar is 66. But on the other end, if a person's blood sugar is 400, we don't really want to be giving them any kind of sugar because we don't want to raise that blood sugar up and make them hyperglycemic. Okay. Again, as I stressed in the other lecture, they must have the ability to swallow. If they don't have the ability to swallow, then we cannot give glucose. Paramedic can give them some glucagon, or it'd be an injection to bring their sugar up, but that's not something that we can do. Okay, so again, they must have the ability to swallow. Another carbohydrate source is allowed. If the person has some orange juice in their refrigerator, things of that nature, we can have them drink some of that instead of giving the glucose. And always remember your scene safety. These hypoglycemic patients may be acting as if they're drunk. A lot of times they're combative, and we need to protect ourselves. Okay, oxygen. Oxygen is technically a medication. Okay, here's your flow rates for your oxygen. Non-rebreather, 10 to 15 liters per minute. Cannula, 2 to 6. Protocol says no more than 6 liters per minute. And your bag valve should be set between 15 and 25 liters per minute. Normally, I set it at 15, and that's more than enough. But if the bag isn't fully inflated as you're bagging the patient, you might want to crank it up to 25. We got to titrate to 94% on their pulse ox. If you have a pulse ox, which most of us do nowadays, if they start hitting 95, 96, that's good. If you're on a nasal cannula, for example, and it's at a low, liters per minute, crank it up to 6. If it's still not coming up above 94%, you want to switch them off to a non-rebreather, okay? And just remember, the pulse oximeter is a tool. It's an excellent tool, and it's very reliable normally. But if you suspect that the patient is hypoxic, we need to administer oxygen. So what this means is that sometimes if your fingers get real cold or certain other nail polish, things of that nature, it's going to affect your pulse oximeter reading. So if you suspect the person is hypoxic, they have cyanosis, things of that nature, even though your pulse ox is reading 94%, 95%, we should still be administering oxygen because the tool could be incorrect. Prescribed inhaler. So people are going to have, people with asthma, COPD, they're probably going to have their own inhaler. We are allowed to assist the patient with their own inhaler. You may see this when it gets to practical skills exam. If the person has their own inhaler, we can assist them with using it, but you have to look at it and make sure it's prescribed to that person and it's in date, okay? Just some examples of different kinds of prescribed inhalers. There's albuterol, Ventolin, Pro-Ventolin, Pro-Air, Levobuterol, and Combivent, which is a duoneb inhaler that has albuterol and another medication in it, okay? But we don't actually carry any of these inhalers on our ambulances. Nitroglycerin. We talked about nitro briefly. When we're administering nitroglycerin, we have to make sure that their blood pressure is greater than 120 systolic. So if their blood pressure is below 120 systolic, we cannot give nitroglycerin. See, what nitroglycerin does is it'll lower the blood pressure drastically. And we don't want to kill that person, so our protocols say their systolic blood pressure has to be above 120. The reason ED meds is in here is formerly it was so that you had to ask them if they've taken any sexual enhancement medications, Viagra, things of that nature, because that can lower your blood pressure as well. So if you give them nitro on top of that, okay, it was not encouraged to give nitro. Now that's actually out of our protocol, so please just disregard that. Okay, when we're giving nitroglycerin, we can give up to 3 doses, and they have to be 5 minutes apart. So the proper way to document this would be gave 1.4 milligram dose of patient's nitroglycerin at 11:30. Waited 5 minutes. At 11:35, gave a second dose of nitroglycerin, 0.4 milligrams, and that's how you document that. We can give up to 3 doses, 5 minutes apart. Beyond that, if the patient you think the patient still needs nitroglycerin, then we need to call medical control at the hospital and say, hey doc, I've already given 3 doses 5 minutes apart, hasn't helped, you want me to give more? And they're gonna say yes or no. Okay, so that's nitro. That's another one you might see on the practical skills exam. Epinephrine is another real important one. We barely ever give it, but this is a major life-saving medication if we do need to do it, all right? It's 2 different doses we're gonna see. Most of us have what's called the check and inject program nowadays, and where we actually draw up the medication with a needle and we'll inject it in the shoulder. The EpiPen still exists. The EpiPens are still in our protocols. But an adult dose, and this may be a test question right here, the adult dose is 0.3 milligrams, okay? A pediatric dose is just half that, so 0.15 milligrams is the pediatric dose, okay? Our protocols allow us to give epinephrine if the person does not have a prescription, and you don't need to contact medical control if the patient is having severe difficulty breathing, facial or oral edema, and or hypoperfusion. So they're showing signs of shock, they're having severe trouble breathing, and they're swelling in their face, their lips, their tongue, all that. Then we need to go ahead and administer it without medical control. Now, if they're showing only 1 or 2 of these symptoms, they're having trouble breathing, they got stung by a bee, and they're having a little bit of trouble breathing. That doesn't mean break out the EpiPen yet, okay? That point, you might want to contact medical control. However, and this is the exception, and this is where it gets a little convoluted, so you really have to look at the protocols and understand what they mean when I say this, okay? with a history of anaphylaxis, which means they've been exposed to, I'm going to use bee sting for an example. They've been stung by a bee before, they had a severe allergic reaction, and they have a history of that. Now, they call 911 because they got stung by a bee. They're not showing necessarily all those symptoms yet when you get there, but you are allowed to give epinephrine at that point. Does that make sense? If the patient has a history of a severe allergic reaction from a known allergen, we can administer the epinephrine without all those serious symptoms. If the patient does not have a history of anaphylaxis and they get stung by a bee, that doesn't mean we give them epi. Only if they're having severe trouble breathing, facial or oral edema, and low blood sugar, high heart rate, signs of shock. Okay, if you guys have any questions about this, please reach out to one of us to clarify. Okay, we can give up to 2 doses total. So we can get them 2 different times, but they have to be 5 minutes apart and documented very, very well. Gave 0.3 milligrams of epinephrine at 11:30. At 11:35, patient did not respond to the epinephrine, gave a second dose of 0.3 milligrams, and that is that. All right, nasal naloxone. Now, this is one we need to be very, very familiar with because more and more, we're getting more and more overdoses, okay? We're going to use this for opioid overdoses, okay? And this is only when the patient has ineffective respirations. So what that means is they're not breathing adequately. You find the person unresponsive, they're breathing less than 10 times per minute, we're going to administer Narcan, okay? If the person took a bunch of heroin, but they're sitting there talking to you, we're not going to administer Narcan. If we get there and they're unresponsive, but they're breathing 12 times per minute and their pulse ox is still in the 90, 94 plus, we don't give Narcan. We only give it to reverse respiratory distress and respiratory arrest, okay? They come in 2 milligram and 4 milligram doses. These are 2 pictures I took of a Narcan that we carry. The one on the left is the old style. You have to take it apart. You pop the purple cap, you pop the yellow cap, you screw them together, and you have a MAD device, which is a nasal atomizing device on the end of it, and you spray it up 1 milligram in each nostril. And I'll show you guys this stuff more in detail when we get back in person. The one on the right is the 4 milligram dose, which is twice, so it's twice the dose. And you can shoot that right into the 1 nostril on the patient, okay? Same thing, you can give 2 doses, but they have to be 5 minutes apart. Nasal Narcan takes a few minutes to kick in. It's not like the IV medications that the medics will give. If they give Narcan IV, it is almost an instant reaction, and the person will wake right up 9 times out of 10. When we give the nasal Narcan, it takes a few minutes to get it worked into their system. Now, the most important thing I can stress to you guys is the reason for giving Narcan is ineffective respirations, okay? What do we do for ineffective respirations? Forget about Narcan altogether. We need to be bagging that patient. We need to manage their airway, and we need to be breathing for them. That has to be priority 1. That's your ABCs. Once we get the person's being bagged, their airway's secure, then we can worry about Narcan. But the first thing we need to do is oxygenate that patient. All right, albuterol. So we can give albuterol. It comes in 2.5 milligram doses in 3 milliliters of liquid. We can use this for anaphylaxis. This should help open up the airways a little bit. We can give it for asthma, we can give it for wheezing, which is associated with the asthma or anaphylaxis. All right, we're gonna set the nebulizer, which I will show you guys. It's a little device that you pour the albuterol into, and you hook it to your oxygen bottle, and you set it 6 to 8 liters per minute. Really, it's 6 is usually adequate. It's whenever the medication starts aerosolizing, and the person will breathe in that albuterol. When wheezing does not always indicate asthma though, so consider allergic reaction. Usually if somebody's wheezing, they're gonna tell you what's going on. I have a history of asthma and I'm having an asthma attack. Or I got stung by a bee and I'm allergic to bees and now I'm having trouble breathing and they're having the wheezing, okay? It could be an airway obstruction, pulmonary issues, okay? There's no age restrictions on albuterol. So you can just give that dose if they meet the criteria. Okay, that's a crash course for you guys in pharmacology. Again, there's not a lot to it. The Narcan is very, very important. And as far as testing is concerned, you definitely want to make sure you understand when we use aspirin, when we use oxygen, of course, the nitro. You could see all of those on your practical skills exam. So take a look at this stuff, review this video if you want to. I will show you guys the nebulizer in person. And if you have any more questions, get a hold of me. All right, see you soon.